diagnosed and treated here in the peripheral part of Pakistan, which is Peshawar. So this is the topic of my presentation is Pancytopenia in an elderly patient, a rare but possible
Doctor,
presentation.
hello,
Yeah,
hello. Sorry for the
yeah.
interruption. The screen isn't visible fully. Could you please click on the slideshow option?
Yeah, I did.
The letters are zoomed in, so we couldn't able to see your full presentation. Yes, it's totally fine now.
Okay, fine.
Okay.
So uh, this is a case which we encountered here in our hospital. A 55-year-old gentleman was treated successfully for hepatitis C virus infection with direct antivirals 3 years ago, and his consecutive PCRs were negative. He presented for the third time to our medical outpatient department with progressive weakness, general body aches, and palpitations. Uh, we did his examination. So examination was suggestive of all the findings were suggestive of anemia, and all his signs and symptoms were explained by anemia. Those were like exertional dyspnea, uh, gross pallor of conjunctiva and palm of hands. And apart from this, the only significant finding on examination was some few healed skin lesions on the lateral aspect of the foot. So the history of the patient, if we summarize it, it will be like general body aches for 1 year, easy fatigability for the last 9 months, and palpitations for 3 months. So all these signs and symptoms suggest anemia. So a history of presenting illness, his general body aches, especially the lower half of the body, it partially responded to paracetamol and all the over-the-counter pain medications. He was giving history of low-grade intermittent fever, but there was no documented evidence. So as well as for weight loss, and this fatigability started like 1 year ago. He was finding it difficult to cope up with his routine activities. There was no history of any drug abuse or any other psychiatric issues that could cause these symptoms. There was no history of chronic illness. Only the symptoms were suggestive of anemia, and he was given cause near the lateral malleolus. Okay, so the past history, he was treated for hepatitis C infection, which is now a treatable and eradicatable disease now. So he received direct antivirals, and his two consecutive PCRs were negative. Apart from this, in his previous 2 visits to the outpatient department, it was generally considered as an iron deficiency anemia, and he was given some iron supplements, and he responded to it. But again, he presented to the hospital with these signs and symptoms. He was exposed to silica at his work sites. The drug history traveled, family history, it was significant for tuberculosis, which is endemic in Pakistan. His brother was treated for pulmonary TB, and his father died of some cardiac illness while his mother was diabetic. Apart from this, his personal and social history, he was a casual smoker for 20 years, and his social economic status was satisfactory. He was a non-vegetarian person with normal sleep and appetite. On detailed inquiry about the sexual history, his history was significant for MSM, men's sex with men, in early 80s. So on the basis of our history, we had these differentials in our mind, like iron deficiency anemia, pancytopenia, iron deficiency anemia, could cause blood loss anemia. So the whole range of iron deficiency anemia were in our mind when we approached the C infections. We were suspecting some pancytopenia secondary to hypersplenism, as TB is endemic in our area, so we were suspecting tuberculosis in this case as well. And as he was above 50, so we were also suspecting multiple myeloma, aplastic anemia, and myelodysplastic syndrome. So these were a list of our differentials on history. Physical examination, which I have already mentioned, there were some few skin heel lesions on the lateral aspect of the foot. Otherwise, there was some, conjunctival pallor and signs of anemia. Apart from this, his physical examination was fine. Uh, Lab investigations, we started work up with the baseline and the routine investigations. HB was 5.6, total leukocyte count for 3, platelets for 80. So it was a pancytopenic fracture. Peripheral smear was also like it was not conclusive of any syphilis. His PCR for HCV RNA, it was negative. We were considering whether there is any recurrence of HCV which could cause bone marrow suppression or hypersplenism, but it was also negative. HIV was also negative, which could cause pancytopenia in this age. So the chest X-ray was fine. There was no evidence of cavitation or miliary TB or anything. So ultrasound of abdomen and pelvis, it was his liver was showing a bit coarse echo texture, but there was no full-blown cirrhosis and all those things. And apart from this, the metabolic profile, the ferritin level, B12 levels, and all those were within normal ranges. He has recently received iron supplements. His B12s and folate levels were also within normal range. Stool foracle blood was negative. TFTs, thyroid function test were within normal range. Multiple myeloma workup, the serum protein electrophoresis, X-ray of the skull, there was no lytic lesions in it. His RBS was within normal range, HbA1c was normal, MAN2 test was negative. So all these, the routine investigations were negative. And it was not suggestive of any particular diagnosis. So we did an upper GI endoscopy to look for any varicose PRB, but as he had a history of chronic HCV, soon an indication of OGD. So we did an OGD which was showing early esophageal varices without red flag signs. So there was no active bleeding from the varices. This was the electrophoresis result. It was also non-conclusive. So all these the differentials were excluded stepwise, like multiple myeloma, normal skull X-ray, normal serum calcium, strep was normal. For aplastic anemia, myelodysplastic syndrome, and miliary TB, we did the bone marrow aspiration with trephine biopsy. So the bone marrow report was suggestive of peripheral destruction, keep inconsistent with iron deficiency anemia, and but nature is not that simple. Trephine biopsy reveals something very important. Trephine biopsy, in our setup, we are not living in a third world country, so the resources are not that good in our setup. So when we received the report, we were in early TB, or maybe there is some issue with the running the refined biopsy. So again, they were all the all hematology department viewed that there are caseation necrosis. So it narrowed down our differential list to the causes of those diseases which can cause caseation necrosis. So our differentials was limited to these four conditions: disseminated histoplasmosis, disseminated coccidiomycosis, TB involving bone marrow only, which is usually called cryptogenic TB as well, and virulosis. So cryptogenic miliary tuberculosis involving bone marrow was also one of our suspicions. So as they say, learning medicine is a continued process of learning and unlearning and then relearning. So we did the same, and we went back to our textbook, the patient, and a respective analysis was done, and we found out that this caseation necrosis in bone marrow could be a presentation of gammas in a bone marrow. Gammas, which is a manifestation of tertiary syphilis. So we start thinking of for these line as well. And when we did the VDRL, which came out positive. Here I must confess that when we took the history of men sex with men, we should have tested him for VDRL, but this thing we missed in the start, and we were not expecting Pancytopenia to be caused by syphilis. So this is what happened in the end when we burn out all our resources and we excluded all the common diseases first. We came toward the rare causes. Syphilis was one of them. So VDRL came positive, and then PPHA was also positive. And the history, the skin lesions, which we contacted with the dermatology, and they also said that the painless ulcer can be extragenital as well. It's not necessary that these the painless ulcer, which are usually in the penile and the genitals area, that could be extragenital as well, and the heme lesions on the skin could be due to the syphilis as well. So a brief intro of syphilis: it is a chronic system infection caused by spirochete treponema pallidum. It has many subspecies, and subspecies pallidum causes venereal syphilis, endemicium cause visual or endemic syphilis, caritium cause penta, pertini cause yas. So a brief view of syphilis includes primary syphilis, secondary syphilis, latent, tertiary, quaternary, and congenital syphilis. And when we want to investigate syphilis, we can do it with microscopy, culture, serology. And there are some tests which are based on treponema, and then there are some tests which are non-treponemal based tests, and we can do PCR for syphilis as well. So VDRL is a non-specific test. It is a non-treponemal test, while the treponemal test or EIA, CIA, PPHA, all these tests. So we can, when we first do a non-specific but a very sensitive test which can pick whether there is suspicion of syphilis or not. So we first do VDRL as a part of protocol. So when it came positive, we did the TPHA. So the result was also positive, so which shows that there is some active infection. And there are some conditions which can give false positive serology for syphilis. And in our case, HCV infection, it could be one of the cause of false positive. But in his case, he was treated successfully for HCV, and there was no evidence of hypersplenism, because in hypersplenism there should be increased retic count, which was completely normal, and peripheral smear. So there was no evidence of hypersplenism and active HCV infection, and there was the other conditions were also ruled out. And the other thing which we need to do is in tertiary syphilis, which is one of the indications of we should do the testing of syphilis on CSF as well. But in our case, the patient denied CSF examination. So then there is a treatment for syphilis in early syphilis, and in their context, we should use IM intramuscular 2.4 million units of benzathine penicillin, which cure the patients in 95% of the cases. And in case of late syphilis or syphilis of unknown duration, we do 7.2 million units of benzathine in total. And in tertiary syphilis, if CSF is normal, 7.2 million units in total should be given. And if abnormal, treatment for neurosyphilis, aortic regurgitation, and aneurysm don't reverse with it. Okay, so in penicillin allergic patient, we give 2 weeks of doxycycline for early syphilis and 4 weeks of doxycycline for late syphilis. And in pregnancy is an exception where if even the patient is penicillin allergic, we start with desensitization, and penicillin is indicated even in that case. So we first do desensitization and then treat the patient with penicillin.